Perfecto. Well, good night, everybody. Welcome to our monthly webinar sponsored by the Paraguayan Society of Ophthalmology and organized by the Cornea Club Internacional. We would like to thank Laboratorio Zaval for the usual help. And it's my pleasure to, my fellow members, please join me in giving our guest, Dr. Sayan Basu, a warm welcome to this webinar. It's actually good morning over there, right, Dr. Basu?
Yes, it's 7 o'clock in the morning. Good evening, everyone. Great to be here.
Good. It's also my pleasure to introduce you to our host for the night, Dr. Miguel Srur from Chile. The program will be a short introduction, and then you will be giving your lecture, and then we go straight to the questions if we got time. I will be monitoring the YouTube channel and hand the questions over to you guys. All right? So, Dr. Miguel Srur, el micrófono es suyo.
Okay, muchas gracias. Sayan, I will introduce you in Spanish, since all the people speak Spanish here. El Dr. Sayan Basu es director y profesor del Brian Holden Eye Research Center y director del Centro de Regeneración Ocular, CORE, y de la Cátedra Binder San Juan de Oftalmología Regenerativa. Es profesor adjunto de oftalmología de la Facultad de Medicina de la Universidad de Rochester en New York y recibió su formación clínica en córnea, catarata y superficie ocular en el Instituto Prasad, Hyderabad, y tiene un fellow de investigación en biología de células madre en la Facultad de Medicina de la Universidad de Pittsburgh. Es sin duda un prolífico cirujano de trasplantes de córnea, de todas las técnicas y así mismo de catarata, con miles de procedimientos a su haber. Es reconocido internacionalmente sin duda por sus avances innovadores en la terapia con células madres, la técnica SLET y el implante de queratoprótesis. Hemos leído, y probablemente él fue el precursor de impulsarnos a nosotros a hacer esta técnica en Chile desde algunos años. Y él ha recibido distintos premios, entre ellos el Achievement Award de la Academia Americana de Oftalmología, y es miembro del editorial de distintas revistas importantes mundiales de oftalmología. Ha publicado muchos artículos relacionados a este tema y actualmente está desarrollando una clínica de ojo seco de última generación, trabajando en impresión de córneas en 3D y desarrollando nuevas terapias con células madre. Dr. Basu, welcome here. You can proceed with your talk, please.
Thank you, Dr. Miguel, for the kind introduction. Thank you, Juan Carlos, for the invitation. It's an absolute pleasure to be speaking to you all tonight. I'll quickly move on to my presentation, and we will try to have some Q&A questions after I finish. Hopefully have some interaction. So I hope all of you can see my screen.
Perfect, Sayan.
Okay, let me just go into slideshow. All right, so I'm going to talk to you about limbal stem cell deficiency and decision making, and what are the surgical options for treating limbal stem cell deficiency for restoring the ocular surface, as well as improving vision in patients who are affected by this blinding condition, and kind of help you understand what are the different approaches that are available, what is it that we prefer and why, and also at the end give you a kind of an algorithm or suggestion as to how we can use the different approaches in different situations. I do not have any financial interest or relationship to disclose. Everything that I'm going to tell you, nothing proprietary. So we follow this algorithm for the surgical management of limbal stem cell deficiency. And towards the, in the middle of the presentation, I will also talk to you a little bit about what limbal stem cell deficiency means according to this definition and so on and so forth. So if you have a patient with unilateral limbal stem cell deficiency, which means that one eye is affected and the other eye is absolutely normal, the management options here basically depend on whether you're going to surgically intervene or not, depends on whether there is visual potential in the blinded eye or not. And if visual potential is present, then whether there is dryness of the surface or not. So if it is a wet eye, has visual potential, then we usually attempt autologous limbal stem cell transplantation, with or without conjunctival autografting, depending on what is the extent of the symblepharon. And we usually do not do a corneal transplantation and wait for some amount of stromal clarity to return over time. So this is our preferred approach in that case. Whereas if visual potential is not present, or if it's an extremely dry surface but unilateral, which means that patient has one good eye, can see in that eye, and therefore is not visually disabled, we would do something cosmetic by giving them a prosthesis or a contact lens. If it's a case of bilateral limbal stem cell deficiency, now this is a completely different scenario because the patient is blind in both eyes, or at least has severe visual impairment in both eyes. And here, improving cosmesis is not going to help. You have to restore vision to the patient so that the patient can see at least through one eye. And therefore, the approaches can be, again, depending on whether it is a wet eye or a dry eye, either an allogeneic, which is basically from another donor, a limbal stem cell transplantation with or without a keratoplasty, with systemic immunosuppression. Or another alternative approach would be to do a Boston type 1 K-Pro. But again, if the eyes are dry, then it's a much more complicated scenario where the only option left for you is keratoprosthesis, but much more difficult types of keratoprosthesis like the modified osteodonto, type 2 Boston K-Pro, the LVP keratoprosthesis, or the Lux keratoprosthesis. And again, if the patient is bilaterally blinded from LSCD, but there is no visual potential, then you're only going to aim for, again, cosmetic. So the important thing to realize in this algorithm is that in bilateral limbal stem cell deficiency and unilateral limbal stem cell deficiency, we don't go for stem cell transplantation if the eye is dry. And we do not go for keratoprosthesis usually if the condition is unilateral. We only think of keratoprosthesis if the condition is bilateral. And depending on whether it is unilateral or bilateral, if the eye is wet, then you are going to choose between autologous. If it is one eye is good, you can take cells from the other eye, or allogeneic if both eyes are affected and you're going to take the cells from a donor. There are certain exceptions. For example, we have seen that in patients with partial limbal stem cell deficiency or conditions such as pseudopterygium, you will find that these patients do not necessarily require a limbal stem cell transplantation, because you can see here in this photograph very clearly that the superior almost 180 degrees, you can see very clearly that the limbus is intact and there is no other problem. But you can also appreciate that there is limbal stem cell deficiency inferiorly. These cases can actually be treated very successfully, just like a normal pterygium, by just doing a conjunctival autograft. Not even a conjunctival limbal autograft, but just doing a conjunctival autograft, like in this particular case. And they will usually give very satisfactory and long-term outcomes, and the patients will usually be very, very happy with these outcomes. So there is no need actually in partial limbal stem cell deficiency to go for a limbal stem cell transplantation. So most of what I'm going to talk to you about today is total, complete, or near total limbal stem cell deficiency, the more severe types. Now, in our scenario, most of this limbal stem cell deficiency is caused by chemical or other kinds of burns. In the more developed parts of the world, the causes are different. Most of them are because of repeated surgery or prolonged contact lens wear, or even chemical injury. Stevens-Johnson syndrome are usually minor causes of limbal stem cell deficiency, but it is either that or healed infections and so on and so forth. So the causes of limbal stem cell deficiency can really vary depending on which part of the world you are and what is the prevalent indication or the cause of this condition in that place. One of the things that you have to make sure before you decide on treating a patient surgically is to confirm the diagnosis of limbal stem cell deficiency. Now, there has been a lot of discussion on this subject. We have some consensus now after a long time, and usually we diagnose limbal stem cell deficiency based on our clinical appearance and fluorescein staining, as you can here see on the top left. But it is recommended that we either do confocal microscopy to demonstrate the loss of the corneal epithelial cells, or impression cytology to show cytokeratin markers that are specific for corneal or conjunctival cells, or do high resolution OCT to show that there is a loss of the transparent epithelium on the corneal surface with thickening and scarring and so on and so forth, or angiography to show loss of the limbal vascular arcades. So in addition to the traditional clinical diagnosis of limbal stem cell deficiency, it is recommended that we also try to establish the diagnosis objectively through other imaging techniques, which is very, very important. Now, once you have diagnosed the patient with limbal stem cell deficiency and confirmed the diagnosis using these advanced imaging techniques, the question is, which technique of limbal stem cell deficiency do you want to use? Now, like I told you before, depending on the source of the donor tissue, you're either doing autologous or allogeneic treatment. But the surgical technique itself, again, there is some variety. The first technique that was described is the conjunctival limbal grafting, which if it is taken from a cadaveric donor is called a keratolimbal grafting, or if it is taken from a living donor is called a conjunctival limbal allografting. You have the ex vivo cultivated limbal epithelial transplantation, or CLET, which was described in the late 90s and now is available commercially in Europe and some parts of North America commercially as Holoclar. And then you have our technique of simple limbal epithelial transplantation. Now, we began our limbal stem cell deficiency treatment program way back in 2001, 2002, originally with conjunctival autografts, allografts, and then we moved on to cultivated limbal epithelial transplantation. So we actually have quite a large experience and in fact have the largest group of patients who have been treated by the total number of patients exceeding 1,000. And this was from 2001 to 2013, and very successful results, over 75% success rates, as you can see in the photographs in the bottom panel, starting off with limbal stem cell deficiency and with ex vivo CLET, the cornea clearing and the epithelium stabilizing over several years. And we have numerous publications on this technique as well. But what we realized after several years of experience is that we could use the same rationale or principle for developing much simpler techniques of doing the same thing and achieving the same results. So that is basically the inspiration behind simple limbal epithelial transplantation, or SLET. SLET also has some similarities to techniques that are used in dermatology. One of the techniques is called the Meek technique, which is used for treatment of vitiligo or depigmentation. As you can see here, there's a depigmented patch on the patient's forearm. So you can take a small patch of pigmented skin from another part of the body, but instead of covering the entire area that you want to treat, you can make these small bits of tissue and then use that, implant that, and then the pigment and the epithelium spreads from that to fill in the blanks. So this is basically a fill in the blanks principle. In the same way, this is also used for treating extensive burns, like I said, with the Meek technique, where you take a small patch of normal skin and it is cut up into small pieces. And instead of harvesting a large skin graft, when patients have extensive burns, you may not have too much of intact skin to harvest a large graft from. So you take a small graft, but you divide that into small parts, and you allow the in-between blanks to be filled in from the epithelial cells that are growing out from these tiny islands of grafted tissue. So SLET basically is the same principle. We remove the pathological pannus from the eye. We take a small amount of limbal graft, which we cut up into small pieces and distribute it over the corneal surface. And as the cells grow out from each of these islands, it populates or the surface around it and fills in the blank. Now, if you look at actually how the healing happens, and all of this is again published and available in existing literature, that this is what it looks like on the first post-operative day, and you can see these tiny bits of tissue. And as time goes on, this is post-operative day 2, and then day 5 and day 7. As you can see, with time, there are, the fluorescent staining is disappearing because the epithelial cells are growing out of each of these pieces, and eventually these small islands of epithelium are becoming large continental sheets and then filling the entire surface. Similarly, OCT also shows essentially the same process. Initially, you see the epithelium moving out or growing out of the limbal transplants, then forming a contiguous sheet between two transplants, and then repopulating the entire ocular surface. Now, the indications for SLET, this is very important to understand. I alluded to a little bit in the beginning that you have to make sure that the diagnosis of limbal epithelial stem cell deficiency is confirmed, preferably by some objective means. It is a wet eye. Please do not attempt cell-based therapy in eyes that have xerosis or keratinization. The underlying stroma must be relatively clear. Otherwise, the patient will not perceive any benefit from therapy if there is too much of stromal scarring. There should not be advanced adnexal damage. If there is adnexal damage like entropion or ectropion or lag of thalamus, that must be corrected before surgery. Preferably done in unilateral cases. These are the cases that give the best results. Preferably total or complete LSCD. Like I mentioned before, it is not necessary to do limbal stem cell transplantations in patients with partial or subtotal limbal stem cell deficiency. And the best outcomes are those in cases of alkali burns and chemical burns. Again, preferably without severe symblepharon. If there is extensive symblepharon that is extending up to the corneal surface, etc., then it's probably a good idea to combine SLET with a conjunctival autograft. So I'll give you certain clinical examples. So you can see all of these cases would qualify as limbal stem cell deficiency. Some of these are chemical burns, some of these are chronic allergy, some of these are Stevens-Johnson syndrome, some of these are cicatricial pemphigoid. But SLET is not going to work in all of these cases. Okay. There are certain cases like the ones that you see on top where you have a very thin pannus, nice clear underlying stroma, wet looking eye, normal eyelids, good exposure. These are the ones with SLET will work very well. Whereas in the bottom row, you have cases where there is dryness, opaque stroma, stromal thinning, symblepharon, entropion, etc., where obviously this therapy is not going to work because of a unwelcome environment that is there in the eye. I'll just show you a short surgical video of the surgical technique. We basically mark the conjunctiva from where the limbal biopsy is going to be taken. We do not directly mark the limbus because there is alcohol in the marking pen, and therefore you don't want to damage the limbal cells. And we lift a small limbus-based conjunctival flap and then dissect the limbus from the conjunctival side. And this is the total width of this dissection is about 1 clock hour, which is between 3 to 4 millimeters. And we dissect just a little bit into the corneal stroma, limbal stroma, remove the conjunctival part and take only the limbal part for transplantation. This is very, very important. There is no conjunctival element that is used for transplantation, unlike conjunctival limbal autografting. And in the eye that has the limbal stem cell deficiency, we do a 360-degree peritomy with conjunctival scissors and then a dissection to lift the pannus or separate it from the underlying stroma in the cleanest way possible. And depending on whether the patient at the initial stage of the burn was treated by amniotic membrane grafting or not, it is easy or difficult to remove the pannus, but mostly it comes off. And then we put an freshly preserved amniotic membrane graft on the corneal surface, stick it down with glue. And again, this is a technique which does not require any sutures. It is completely sutureless, and we use only fibrin glue. Once the amniotic membrane has been spread nicely over, then we take the limbal graft and we cut it up. Usually this 3 to 4 millimeter graft, the optimal number is between 8 to 10 pieces. And we distribute this in a in a circular fashion, annular fashion around the cornea. And then again put drops of fibrin glue on top of each of these individual pieces to secure them in place. And these pieces again, not too much glue, just a little bit of glue, that is enough. You just wait for a minute for the glue to gel. And once the glue has gelled in place, you can put a contact lens on top, and that is the end of the surgery. So it is the surgical technique per se is very straightforward, and hence the name of simple limbal epithelial transplantation, to contrast it with other forms of limbal stem cell transplantation which are more complex. And you can see here that this is the first images that we published in our original BJO paper in 2012. So on the left, you have patients with total limbal stem cell deficiency, and you can see with SLET at 1 week, 1 day, 1 month, and then at 1 year, the epithelial surface getting restored, the cornea clearing up, and obviously with that, the patient's vision also improving. Subsequent to that, we have published a large series of 125 cases. Till date, we have performed more than 500 cases of SLET, both autologous and allogenic. Several publications on this. If you just go on PubMed and look for these. It's very easy to find. There are other groups that have also published on this, quite large series between 30 to 50 cases. And one of those included a multicentric study, which included our friends in Mexico, in the United States and other countries. And what is remarkable is that across the board, people have reported similar success rates of between 75 to 80% in autologous LSCD. And like I said, if you keep in mind the contraindications that I mentioned in the earlier slide of how to choose the cases that are ideal for SLET, your success rates can be as high as 95% or 100%. In today's times, at our center, SLET carries a success rate of close to 100%. Now, how is it different from cultivated limbal epithelial transplantation and conjunctival limbal autografting? The main differences, I would say, is first of all, unlike cultivated limbal epithelial transplantation, you don't require a stem cell lab. Most of you who are attending this lecture today don't have a stem cell lab to access. Maybe in the future, when stem cell therapy becomes more common and stem cell labs are more accessible and it is more affordable, then this would become the standard of care. But I don't see that happening in the near future. And it is definitely not available for us who are in clinical practice at this moment. So it is kind of an impractical solution unless you are willing to spend thousands of dollars, or insurance in your country is willing to spend hundreds of thousands of dollars to pay for holoclub, which that is how much it costs. Because you're taking a very small amount of donor tissue, again, there is no risk to the donor eye, and therefore compared to CLAU, where you take between 4 to 6 clock hours of tissue, it has a much greater benefit and lower risk profile. And the success rates have been proven. There is a recent systematic review which has been published in the British Journal of Ophthalmology, which actually shows that if you review all the literature of published studies, you find that SLET is actually much more effective than CLET overall. I will, however, give you two exceptions where I would prefer using a conjunctival limbal autograft as compared to SLET. One of them is in LSCD with opaque stroma, where you also have to do a corneal transplant. There, I think a combination of a lamellar or a full thickness transplant with a mini or a full CLAU is better, because the corneal graft, like I have shown in this example, because the corneal graft still remains high risk for rejection because of the other underlying problems of vascular bed and intraocular inflammation and so on and so forth. And therefore, the limbal graft that you put stays in its anatomical place. And if you need to repeat the corneal graft, that will not result in loss of the transplanted epithelial cells, which would happen in SLET. And the other is with subtotal LSCD and severe symblepharon, like I mentioned in the beginning of my talk, which is basically what we refer to as pseudopterygium, where I would prefer to do only a conjunctival autograft or a conjunctival limbal autograft rather than doing a SLET in these cases, because you have a conjunctival and limbal problem in a sectoral area, which you can easily solve with a sectoral conjunctival limbal graft. Just to finish the talk with some case studies, this is a patient that we operated in 2011, and you can see the amount of vascularization and scarring on the ocular surface, which has improved tremendously over time. The patient last followed up in 2018, and you can see that the patient's uncorrected vision has improved from light perception to 20/40 over time. So there is some amount of stromal remodeling that also occurs after SLET. So you may not necessarily have to jump into doing a corneal transplantation if the underlying stroma is not so clear. There is usually gradual stromal clearing over time. The other dramatic illustrative case is this, where the patient presented with an ocular surface granuloma and basically came for enucleation and an implant, but we convinced the patient and the patient's attendant to undergo SLET instead. And this is the same patient who came in 2018 for follow-up after 7 years. Now he's an 18-year-old boy, and you can see that his left eye is just as normal looking, and his right eye, you wouldn't be able to make out that he even had surgery and this very gross, ungainly lesion in his eye previously. So this is the kind of dramatic impact that SLET can have if the correct cases are chosen and the surgery is done properly. And just to finish with the last example, another small boy, 6-year-old with a chemical burn from Bangladesh, who came with, and you can see again over here, a total and quite severe limbal stem cell deficiency, treated with SLET, and the outcome in these cases, it can't be more gratifying than this. The patient has an uncorrected vision of 20/40 and an eye which just looks as normal as anybody else's eye. So it is not just an surgery which improves the ocular surface, but also improves cosmesis to a very large extent, and it dramatically improves vision. So the only thing that I'll say at the end before concluding is that if you have access to epithelial cell culture, if you are involved in research in ocular surface and have access to a stem cell lab, sure, you might look at the option of cultivated limbal epithelial transplantation. But otherwise, for all practical purposes, your choice is between conjunctival limbal autografting and SLET. SLET is definitely the simpler technique, but if you are doing complex reconstruction, which would require addressing a huge symblepharon or corneal scarring, or would require cataract surgery, also you're planning a triple procedure, then it might be better to do a CLAU. Otherwise, for 90% of cases, you will get very, very good results with SLET using the algorithm and the inclusion criteria that I mentioned earlier. So thank you very much for your attention. And if we have about 10-12 minutes for questions. Unfortunately, I have to go in about 12 minutes for another meeting. So I'll be happy to answer any questions that you have. Thank you so much for inviting me and giving me this opportunity to present our work. Thank you.
Thank you, Sayan. I have a couple of questions.
Sure.
Do you use, in some cases, immunosuppression agents or angiogenic agents?
If you are doing an allogenic SLET, which is just as easy to do at an autologous SLET, in a bilateral limbal stem cell deficiency, we have done quite a few. The results are also published. If you're doing allogenic, either from a living donor or from cadaveric tissue, then you, like any other allogenic graft, you have to give the patients immunosuppression, systemic immunosuppression. Having said that, and we usually use a combination of oral steroids and cyclosporine. You can also use tacrolimus. Having said that, I will tell you this, that because the transplants are placed in the on the cornea and not at the limbus, so you're placing the transplants on an avascular bed and not on a vascular bed like the limbal stroma, the amount of immunosuppression that is required to suppress rejection is much, much lower than you would need for a keratolimbal allograft or a conjunctival allograft, and definitely less than what you would need for any other solid organ transplant, like liver or a kidney, so on and so forth.
Do you have any experience or you used before with cadaveric donors of limbal cells?
We have a lot of experience with cadaveric donors. They work very well. I would just recommend a few tips to select the right kind of cadaveric tissue. You know, when we are doing corneal transplantation, and most of these tissues will come from the eye bank, we only focus mostly on the stromal clarity and the endothelial cell density. When you're doing a limbal transplant, you have to look at the epithelium and the limbus. And unfortunately, when tissue is in storage, what happens is that the epithelium sloughs off and the limbal epithelium also gets damaged. So if you are planning a cadaveric allogenic transplantation, make sure that you use tissue with the shortest possible preservation time and with visibly identifiable palisades. Sometimes, you know, the way that the tissue is harvested, there's hardly any limbus left in the rim. So those are the two things that you have to pay attention to: short preservation time, as young a donor as possible, and a tissue with visible palisades.
Excellent. And what do you do to select some cases in children cases? There are a little bit worse results with children than the adults. There are some kind, how do you prefer or how to select those kind of children to perform surgery?
In children, you know, SLET actually does very well. The cultivated limbal epithelial transplant or CLET does not have very good results. It also has to do with the fact that when children get these burns, particularly in developing countries like India, they tend to have much worse injuries. So their injuries are much more complicated. The nature of the burn is much more complicated. And that essentially is what determines the outcomes. Otherwise, if you are using the same SLET selection criteria for doing SLET as you are using for adults, I would not really anticipate any difference in outcomes. Having said that, I will give you some pointers. For example, in children, it is extremely difficult to do a post-operative examination without putting them under anesthesia because, you know, of the tissue edema, etc. Their eyes are swollen, and unlike adults, they are not, you know, it's very difficult to examine them and so forth. So we will usually, in very young children, like those less than 6 years of age or 8 years of age, we will usually do a temporary tarsography to make sure that the contact lenses and the pieces stay in place, because children have a habit of, you know, very young children, for example, they'll rub their eye, etc. And that can be detrimental. So certain protective measures like doing a temporary tarsography for the first week, giving them a little bit of oral steroids to reduce the inflammation quickly. Those are things that we do additionally in children that we usually will not do for adults, particularly for autologous grafts.
Excuse me, but you are still talking about needing long-term systemic immunosuppression for the graft survival, right?
If you are doing allogeneic, not if you are doing autologous.
If you're doing allogeneic, are we talking about topical ones or oral?
Both. If you are doing an autologous SLET in a patient with unilateral limbal stem cell deficiency, then we just give them topical steroids in tapering doses for the first 4 to 6 weeks. That's it. After that, they're not on any immunosuppression. But if the patient has had an allogenic graft, then you have to give the patient both topical and systemic immunosuppression, just like you would do for a high-risk corneal graft.
For how long time?
For as long as the patient will. You know, the risk of rejection never goes away. The longer the graft is in the eye, the higher the risk of rejection.
I would like to read a question from Jaime Martinez from Bascom Palmer. He's asking, have you ever taken more than one limbal stem cells from the healthy eye for repeat SLET? If yes, more than 2?
Hi, Jaime. What I would like to say is that yes, I have done that rarely. Which means that you're repeating, either you're doing the SLET. So we have a series that we have published in VJO on repeating SLET in patients who have failed CLET. So we did CLET first, it failed, and then we did SLET. So we are taking a second biopsy from the eye. So we have done that. I think if you're taking, because the size of the biopsy is so small, I don't think that it has any risk to the donor eye. However, I will say this, that if you have done at least 2 procedures, maybe a SLET or a CLET or 2 SLETs or a CLAU and a SLET, if you have done it twice already and both times the surgery has failed, then you do need to pay attention to the local factors which are responsible for the failure. So there is something that we are missing in that case that also need to be paid attention to. Otherwise, particularly autologous limbal stem cell transplantation, if you are have fixed everything else, should succeed. So if it fails once, maybe technical issue repeated, but if it fails twice, I would pay close attention to both the donor and the recipient eye to understand why this is happening, so that can be prevented instead of just doing repeated procedures.
What about your threshold when it comes to decide if you're going for the SLET in combination with a anterior lamellar transplantation? I know you use the OCT and the infrared camera to kind of see how scarred the tissue is. What's your threshold to decide if you go for a transplant already and in combination?
So I will, what I'll tell you is I'll never actually attempt a corneal transplantation with a limbal transplantation at the first go. If I have decided that I'm going to do a SLET for a patient and my preoperative evaluation using the OCT has shown that the cornea is not wafer thin, or that it is not severely scarred, or the patient doesn't have an adherent glaucoma and so on and so forth. In that case, I will do a SLET first and wait for the cornea to recover, assess after 6 to 8 weeks to what extent the cornea has recovered, do a contact lens trial, maybe a scleral lens, to see if I can improve the patient's vision with non-surgical methods, do a dilated examination to see maybe the vision is poor because the patient has a cataract or a retinal problem and so on and so forth. And usually that is 99% of cases. If I know from beforehand that the patient will need a corneal transplantation, whether a lamellar graft or a full thickness graft, in that case, I will plan a conjunctival limbal graft, usually a mini conjunctival limbal autograft with a PK or an LK. In that case, I'll not combine a SLET with a corneal transplant.
Okay.
Sayan, are you using cross-linked amniotic membrane?
What we use is the freshly preserved membrane. So I don't have any experience with cross-linked membranes. We do have the freeze-dried and lyophilized membrane available commercially, but it doesn't really work very well for SLET. It is a little bit less, it's a little bit more fragile or brittle, and doesn't really stick down very well with glue. So you can still use it, but you have to use sutures, etc. So, but the cross-link membrane, I really don't have any personal experience.
Okay. There's another question from Christian Cartes. What are you doing for bilateral cases?
So, like I said, you can go back to the YouTube video and look at the algorithm that I presented in the beginning. If you have a case of bilateral limbal stem cell deficiency, if the eye is wet, you can definitely attempt a allogenic limbal stem cell transplantation, whether it is SLET, CLET, or CLAU, or KLAL or CLAL, and along with a corneal transplantation with immunosuppression. Most surgeons in today's day and age prefer doing a Boston type 1 keratoprosthesis instead of going through this complicated route, because it is available everywhere and people are trained to do it. If it is bilateral and dry, in that case, you will have to do a type 2 keratoprosthesis.
Do you think there are any improved using a double amniotic membrane as a sandwich, or just a single one?
So my good friend Guillermo Mesqua at Bascom Palmer, he's he was the first one who started using the double amniotic membrane. We have never actually used the double amniotic membrane in the last 10 years, and we have consistently shown good results. And Guillermo also tells me that after the initial 15-20 cases, he also found that it was redundant, and he doesn't use the second amniotic membrane now. So I don't think that it gives you any benefit. But if you have a patient who's not going to come for follow-up soon, you want to make sure that the contact lens doesn't fall off, you might put a second membrane, but I would just put a temporary tarsorrhaphy that would do the job. I mean, amniotic membranes are not cheap, so or easily available. So I don't see any functional benefit of having a second amniotic membrane, but it doesn't do any harm as well. So it's not really required, but if you're doing it, that's also fine.
Okay, great. We are kind of running out of time, I mean, for your next meeting, Sayan. A lot of questions we have here will be answered in your paper I'm going to share tomorrow, the one you published 2019 in the India Journal of Ophthalmology. So I think that will be fantastic for a lot of questions I'm reading here. I wanted to give Dr. Daniel Sanchez, maybe, are you there, Daniel? Maybe do you want to make a question before we leave him be?
So I will recommend, the paper that was just talked about. It is a very, very comprehensive review of the technique, and it's basically like a beginner's guide, and it will answer most of the frequently asked questions on SLET, how to choose cases, what to do, what if you have complications, each type of complications, how you can manage. It's very, very elaborate. There is also, you can look at my YouTube channel where there are a couple of very detailed explanatory videos on SLET, just again to help surgeons who are starting out. And you can also look at our systematic analysis on different techniques of limbal stem cell transplantation, which is published in the BJO. I think these 3 resources will take care of most of the doubts that you have.
Perfect. Dani?
Yeah, great discussion. I think everything was done, everything was said. So congratulations, Dr. Basu. You have changed the way we see this kind of transplantation. Most of the time, we had a lot of bad results in many of the burned corneas, okay? And the SLET changed that thing. So thank you very much.
No, I think what you're saying, it resonates with a lot of people across the world. And a lot of people I have met when we used to travel before the COVID pandemic have told me the same thing. And I'm very glad that things are much easier than they used to be before. And because now more people are doing, more people are getting trained, other people are getting to observe them. And, we have hundreds of SLET surgeons across the world who are doing it very comfortably and very successfully. So I'm very happy because it ultimately, it's the patients who benefit from this. And these are usually patients who are suffering a lot. So that is, I think, the greatest joy that any surgeon can have. And I'm very glad that that is happening across the globe.
Thank you.
Thank you so much. I'm very sorry I have to go because of the other meeting that I have, but it was fantastic to connect to all of you. And if you have any questions that are not answered, please feel free to WhatsApp me or to, send me an email, and I'll be very, very happy to respond. Thank you so much. Very honored and privileged to be present among all of you and to be, giving this talk to you so far across the world. Thank you so much.
Thank you, Sayan. Thank you for sharing time.
Thank you, Sayan. Till next time, yeah? We're going to bring you over to Latin America.
Sure, absolutely.
Have a great night, everybody. Thank you very much for tuning in. And on the last Thursday in November, we're going to have, no sé por qué seguimos hablando en inglés. Sorry, we're going to switch to Spanish. El último jueves de noviembre vamos a tener a la doctora Valeria Sánchez de México, de la APEC, con el manejo de la neovascularización en córnea. Así que quedan todos invitados. Muchísimas gracias a todos los que participaron, especialmente al doctor Miguel Srur, que tuvimos un anfitrión de lujo. Doctor, algunas palabritas para hacer un cierre.
Sí, yo te voy a decir que partimos hace unos 6 años más o menos con esta técnica. La técnica realmente anda muy bien cuando los casos son seleccionados, como dijo él. Los mejores casos son los unilaterales, cuando uno saca un ojo injerto del ojo contralateral, cuando un ojo útil. Y los más malos probablemente son los que necesitan inmunosupresión, porque en nuestros países la gente abandona el tratamiento. Entonces muchas veces vuelven meses después en que no usaron inmunosupresores por costo, tacrolimus, etcétera, etcétera. Y esos son los casos que más mal andan. Y lo que aprendimos es la queratoplastía difería después de haber hecho un SLET y de haber mejorado la superficie del ojo. Cuando hicimos casos simultáneos no anduvieron muy bien. Así que la técnica es muy buena cuando está muy bien indicada. La selección no es una técnica difícil tampoco.
Sí. Realmente las contraindicaciones son los ojos severamente secos, triquiasis, alteraciones palpebrales, como él dijo, un ambiente, dijo una palabra, dijo un medio ambiente enemigo para el procedimiento, ¿verdad? Entonces cuando no es, ahí no funciona, ¿verdad? Lo otro que habían preguntado también es cuánto tiempo se puede utilizar el trasplante cadavérico. Y en el paper que ellos publicaron hablan de 48 horas, hasta 48 horas para poder tener la mayor cantidad de factores parecidos a una córnea en vivo, ¿verdad? Para que pueda tener ese efecto, ¿verdad? También recomiendan tomarlo de la zona superior, donde las palizadas de Fock son un poquito más grandes. La diferencia grande también es de que esto toma solamente 1 hora de reloj, que equivale a como 3-4 milímetros, a diferencia de las otras técnicas que tomaban realmente 4 a 6 milímetros arriba, abajo, y lo cual podía también llevar como un riesgo a la deficiencia de células limbales del ojo donante, y ahí sí estás en problema, ¿verdad?
Así es.
Una acotación, Juanca, si puedo, que es importante y que diferencia lo que es el trasplante de células limbares con la técnica SLET del trasplante limbo conjuntival ubicado en el limbo. Cuando se hace un SLET y se optó por no tocar la córnea y la córnea después está opaca, si nosotros hacemos un trasplante lamelar anterior después, nosotros vamos a retirar todas las células que están en la córnea produciendo epitelio sano. Y en ese caso va a volver a haber neovascularización. La diferencia fundamental con el trasplante del limbo propiamente dicho, que es limbo conjuntival, es que en ese momento el limbo está más expuesto a que haya rechazo, otro tipo de problemas, pero el limbo colocado a nivel de su lugar inicial, sin que se haga en la córnea, permitiría después hacer un trasplante lamelar si se duda que el paciente tenga opacidad en la córnea. Por eso, cuando se hace un SLET, es muy malo pensar en hacer después de eso un trasplante de córnea lamelar o inclusive penetrante, porque nosotros vamos a quitar todas las células que acabamos de poner para solucionar el problema epitelial. Si pensamos que se va a hacer eso, nosotros siempre tenemos que hacer el trasplante en el limbo, con dos lonjas de tejido importantes, que es el trasplante anterior, el que hacía Kenyon y todo ese grupo de Boston, ¿verdad? Porque ahí sí podríamos hacer y hay un limbo que nos va a renovar las células. Pero si las células se hacen con SLET, eso implica que después no vamos a poder hacer un trasplante de córnea. Vamos a perder la capacidad de esas células que están ahí, ahora en la córnea. Nuestro limbo pasa a estar en la córnea, no en el limbo normal, ¿verdad? Es una cosa que de repente vi un par de casos que se hizo SLET, después se hizo una cirugía de queratoplastia y volvió a recibir la conjuntivalización, porque ahí ya no hay un limbo natural que esté deteniendo a ese proceso de fibrosis.
Lo que ellos mucho, es lo que el grupo de Tseng y de Sayan Basu priorizan mucho, es el uso de la tomografía de coherencia óptica, ¿verdad? Y la cámara infrarroja, que fue justo lo que le pregunté, porque con eso ellos tienen una idea de cuánta cicatriz hay en la córnea y si es que van a necesitar algo más después, ¿verdad? Incluso a ellos les sirve como un parámetro para no hacerlo ya SLET, ¿verdad? Que me pareció súper interesante, ¿verdad? Porque sobre todo para la parte técnica también de cómo entrar a levantar de la periferia, porque a veces las córneas están muy afinadas y puedes perforar y eso es una tragedia, ¿verdad? Sobre todo cuando entraste para hacer una queratectomía nomás, hacerle el SLET cuando perforaste, eso es una tragedia y tenés que hacer un trasplante ahí. Y el pronóstico es malísimo, ¿verdad?
Sí. Sí, habitualmente cuando va a andar el SLET, anda la primera, ¿eh? Ya cuando no anduvo un segundo SLET, ya el resultado del pronóstico es más malo.
Es tal cual. Y elegir SLET para un paciente que tiene una opacidad que asumimos que va a ser importante es una mala idea, ¿verdad? Sus resultados tan buenos son por esa elección. Es un ambiente perfecto, párpados que se cierran bien, muy buena vascularización, y es un problema de trastorno de superficie porque el limbo está muy lastimado. Pero si el estroma tiene cicatriz, el SLET no va a funcionar y después un trasplante tampoco. Entonces el SLET es para esos casos, y los otros casos son sí de combinación de queratoplastia con trasplante de limbo conjuntival o bien de cirugías de trasplante limbo conjuntival y una queratoplastia en segundo término, ¿verdad? Para que la superficie tenga una segunda chance de tener una repoblación.
Bueno, yo creo que el tema va para hablar más. Yo creo que tenemos que invitarle de vuelta también. Y en honor a la hora, ¿verdad? Tenemos una hora, queremos tratar de mantener el formato. Muchísimas gracias por los aportes de todos, por los comentarios y por el acompañamiento esta noche. Especialmente otra de vuelta al doctor Miguel por ser el anfitrión.
A ti, Juan Carlos. Gracias por la invitación. Buenas noches. Chao, Daniel.
Chao. Gracias, Miguel. Muchas gracias como siempre. Gracias.
Chao,
Juanca.
Chao.